Hello, I'm Ted Feldman from Chicago. I'm here with Francesco Maisano from Zurich, Georg Nickenig from Bonn, and we're going to talk about the Valtech Cardioband. So, Professor Maisano, as a surgeon, the Cardioband is something that's old and new for you. Can you just tell us what is the Cardioband?
So first of all, Cardioband is kind of a dream come true. It's a surgical device that you can deliver with a catheter. I think this has been always our dream. And in our hands today is something that is repeatable, it's doable from a lot of operators who can today reproduce surgical standards in a cath lab.
So this is a surgical annuloplasty ring in every way, except that it is delivered by catheter.
Exactly.
So that sounds very complicated. I hear from many people the question, isn't this too difficult for real practice? George, you have a lot of experience with this device.
No, I wouldn't say no. It's doable and it's learnable. Of course, you have a learning curve as you have it with every procedure with mitral clip or other devices. You have to do a few interventions, but you have to get used to the images. And usually the intervention, just navigating around the atrium and placing the anchors is not a problem at all. It's very easy. A PCI can be much more difficult. Imaging is more demanding and you have to get used to that for a while, but it's doable. And as we can see, the technique is rolled out over many centers in the current presence. So I think it can be rolled out to almost every large center.
So you said one word that really caught my attention, and that is imaging. And it seems to me that the biggest challenge in all of the valve interventions has for the interventional cardiologist to learn more about imaging.
Absolutely, and to do the imaging at the right spot. We weren't not used to look at the annulus of the mitral valve or at the annulus of the tricuspid valve. We have to get used to these images, and then we have to just translate that into our intervention.
So we have now, after a lot of work, some data on the Cardioband and some new data presented here. Can you update us, Francesco, and especially about what's significant about the most recent data?
First important message is that Cardioband confirms that transcatheter repair is safe. The data show extreme safety of the procedure in a cohort of patients with high-risk profile. But not only this, core lab adjudicated data shows that we can achieve surgical-like outcomes with annuloplasty, which means that at 1 year follow-up, a majority of patients have no or trivial MR. We're talking about 60 or more % of the patients have trivial or no MR. And I think this is something which is competing with other technologies in this field. What is also interesting to see from the data is that more and more centers are now entering into the study, so that it's not anymore a pioneering state. And I think you know this from your experience in the mitral clip area, how important has been the transition from the very first initial phase to a more teachable, standardized procedure. And I think today this is what we have.
So one thing that I think is really striking to me about the 1 year data is the contrast with the CTS-NET surgical report, in which annuloplasty in patients like this with functional MR had a almost 2/3 recurrence rate at 2 years, roughly 50% recurrence rate at 1 year. So here, to your point, we see at the 1 year mark, no recurrence virtually.
Yeah, we have to be obviously careful to state anything at this time, that the numbers are still small, but obviously there is an interesting difference. Maybe the background of this difference is a little bit of a different in the way this annuloplasty is well fixated to the base of the ventricle. Different from surgery, we control each individual anchor by multiple imaging. In surgery, we control nothing. We just put a suture. So there is a control, the solidity of the implant probably plays a role.
So another thing that I think is really striking at this meeting and in all of our recent discussions in this field is the emergence now of more and more repair technologies and at the same time replacement technologies. So George, how do we integrate repair? Is it repair versus replacement or repair and replacement, or where are we?
Replacement is even a younger technique than Cardioband, so we have to wait a little bit. So he had some key, he mentioned some key findings. First of all, safety. Mitral clipping or the Cardioband is extremely safe. We don't lose any patients during the procedure, and it seems to be very efficient, as we have seen in the one-year data. So I would say in a patient with annular dilation as the leading pathology, Cardioband would be one first-line option for this type of patient. If we have a patient which is not clippable, which has no option for a Cardioband, so a severe degenerative disease, and at the same time a dilated left ventricle, this may be a candidate, for example, for a replacement. But we have to learn more about these replacement issues. We have seen data of 20 to 30 patients per valve. I think we should wait 1 or 2 more years. The devices are still very bulky. We don't know nothing about oral anticoagulation after that, development of thrombosis. So there are a few things to work on.
So you mentioned another really key point, and that is that MitraClip leads this field by many years. Can we see some advantages now to a technology like Cardioband compared to MitraClip when we have to consider maybe one or the other?
Well, first of all, I totally agree with you. There is a huge advantage of MitraClip in this field based on the experience. 40,000 patients, have been generating data, has been generating experience, and a large population of operators. So will still play an important role for many years. On the other hand, one big limitation of MitraClip has been that we have been adapting the patients to the device. We have been treating all comers. And this is not what happens in repair. You have to adapt to the anatomy. So there is a big advantage of having another player in the field. And don't forget that annuloplasty is the most commonly performed repair technique in surgical repair. So in all patients undergoing open surgery, annuloplasty is performed. And if you look forward, annuloplasty can be used as a standalone procedure, but also in combination with other therapies, including MitraClip. There are many advantages we can discuss. The way you interact with the valve anatomy is much softer. With the Cardioband, you can't make the MR bigger than it was before, which may sometimes happen when you interact with the leaflets. So there are several advantages which have to be further investigated. Again, we are very early in the stage. I think the feasibility has been demonstrated. Now it's time to have more numbers to grow this experience.
And maybe to add one more issue or one more very important bullet point. If you do a Cardioband, there are options open afterwards. If you do a MitraClip, you have the MitraClip in the leaflets, and usually the only thing you can do is open heart surgery if you fail with the MitraClipping. If you do a Cardioband, usually you have very good results, but if you don't, then you could go for MitraClipping, you could go still for maybe valve replacement afterwards, or you could go for open heart surgery. So you have many options for the patients. And that makes it also a very attractive option, maybe in the future for an earlier intervention, because it's just a small footprint in the heart and you can still go for many other options with this patient.
Well, we might end on the comment you just made that's very provocative, and that is earlier intervention. How far are we from considering the beginning stages of MR and LV decompensation versus where we are today with, as in the Cardioband data, ejection fractions of 30% and patients who are repeatedly hospitalized?
Yeah, it's a very important point. Obviously, if you have a device like Cardioband, which is safe and brings no detrimental risks to the patients, is not changing the anatomy, is not changing the physiology of the mitral valve, then you can foresee an application in earlier stages. And I think one of the missing opportunities for mitral interventions is that we treat patients at the end of the road. So there is an obvious potential, and I would say that in the area of mitral interventions, there are very few devices which can be used early, and catheter is one of those. I would never implant early a prosthesis. I would probably be a bit reluctant to do a mitral clip in an early patient. So really, this is a new field which is open, requires proper studies, and there is some in preparation in this regard.
Yeah. So hopefully we'll hear at EuroPCR 2017 the beginning of this effort.
Absolutely.
Thank you. I think we've had a really very clear exposition of the status of Cardioband.
Thank you, Ted.
Thank you, Ted.